Good morning, everyone. Thank you for joining us this morning for our webinar titled Black Women and Substance Abuse, Our Past, Present, and Future. This is Shayna Lenove. I am the Fiscal Health Manager at HealthHIV, and I'm excited to welcome you to one of our Sync webinar series webinars today. This webinar is hosted by the National Black Women's HIV/AIDS Network and is part of a series that HealthHIV is conducting throughout the year leading up to our Synchronicity 2019 conference in April of 2019. So thank you all for joining us this morning. As we get started, I'd just like to point out that we have a question and answer box on the bottom left of your screen. You're welcome to use it to put questions in as our presenters are speaking today, and we will get to them at the end. So if you put them in there, we'll save our questions to the end and hopefully be able to get to them all during our presentation today. These are our speakers for today's presentation. Deborah Levine is the Senior Managing Director at Love Heals Youth Initiatives at GMHC, and she will be welcoming Tracy Gardner, who is our faculty for today's presentation. Tracy is the Vice President of Policy Advocacy at the Legal Action Center. And at this point, I will turn it over to Deborah to introduce the National Black Women's HIV/AIDS Network and our presentation for today.
Good morning and thank you. Thank you everybody for joining us and Happy New Year's. On behalf of the National Black Women's HIV/AIDS Network Board of Directors, we're excited to have you be a part of this fabulous series. It gives me great pleasure to introduce our faculty this morning, Ms. Tracy Gardner, who I've had the pleasure of knowing well over 30 years. She is currently the Vice President of Policy and Advocacy. Tracy has spearheaded major initiatives and fostered strategic partnerships that have supported the Legal Action Center's mission and vision. From 2015 to 2017, Tracy served as the Assistant Secretary of Health for New York State, where she oversaw the state's addiction, mental health, and developmentally disabled agencies. Tracy has worked well over 30 years in the health and social service policy arena. Not only is she a policy advocacy trainer and lobbyist, she's an all-around shero, and we're excited to have her join us this morning to share, again, to talk with us about Black women's substance use and where do we need to go next. So welcome, Tracy, and thank you for joining us.
Thank you, Deborah. And thank you to the network and to Synchronicity and HealthHIV for this opportunity to talk a little bit about the current landscape that we're in around the overdose epidemic, and to have some time to really focus in on issues of a concern and just issues to keep a lookout for as Black women, understanding our experiences with health and inequities in health, and that this time of addressing the overdose epidemic is also a time where a lot of change is happening, and we want to make sure that our needs as Black women and our families and communities are met. So, Deborah, go to the slide 7.
You're there.
Oh, not on mine. Okay. Sorry. So just a little bit about Legal Action Center. We're a law and policy organization. We've been around for more than 40 years, fighting discrimination and advocating for good public policy to support people with histories of addiction, HIV, AIDS, or involvement in the criminal justice system. We are the only national organization with these three areas of focus and the intersection of them, and we do our work through legal services, litigation, policy advocacy, and research. And, I like to talk about the fact that Legal Action Center has been around since the first opioid epidemic, and to kind of exist in the arc of history to our current one has been both instructional and somewhat challenging at times. Okay, and another element of our work is a relatively new campaign called No Health, No Justice. It's our campaign for health and justice in the 21st century. And really, it's about understanding the role, the critical role of race in inequities in the healthcare and criminal justice system. We are working in multiple states with stakeholders and advocates to address mass incarceration and to help decarceration by recognizing that a main driver of mass incarceration in Black and brown communities has been the neglect in approach toward substance use disorders and mental health. So when you end, you'll see a way to get more information about Legal Action Center in general and about the No Health, No Justice campaign specifically. And then, again, Deborah introduced me, and probably one of my most important titles is a friend of Deborah Levine, and we have worked on a variety of issues that have emerged in the HIV policy and grassroots organizing arena, and just have some of the issues that I've worked on or some of the campaigns I've led, and certainly some of the issues that Deborah and I have had the pleasure of working together on. So you've got a lot of history and experience on the phone with you. We're going to talk a little bit today about, again, this is not a scientific presentation by any means. I would like to picture us sitting around a kitchen table and kind of talking about issues of the day. And in this particular discussion, just talking about and observing some of the trends and issues as the country struggles with what has been called a prescription opioid epidemic, or a general opioid epidemic, a fentanyl epidemic, an overdose epidemic. But for many of us who've worked in HIV/AIDS in the last 30 to 40 years, we are seeing a number of changes happening to the Health and Human Services landscape in response to the overdose epidemic, and we just want to make sure that we are paying attention to what's unfolding to ensure that we are not, as Black and brown people, left out of the critical policy and funding decisions that are happening at a rapid pace, I would say. So I also want to take this time to acknowledge, there's no new information, and that we as advocates are standing on the shoulders of others, and that we, are committed to being shoulders that others can stand on. When I talk about women and health issues, I always have these researchers and practitioners in mind as people, women who were talking about what was going on and giving us a lens to examine how things were unfolding with HIV and connecting issues with criminal justice, with addiction, with child welfare. So Mindy Fullilove, Denise Shervington, Stephanie Covington, and Beth Ritchie are names you should know if you don't already. So, I like to talk about how did we get here, and again, kind of acknowledging that this is not the country's first opioid or drug epidemic, and that in a relatively short time, we've seen a number of changes in attitude and responses to the quote-unquote drug crisis, or the, as we call it, the war on drugs, which we all understand is very much informed by racist policies that have informed the history of this country, and where race has been a factor in just about every approach to our issues. So obviously the war on drugs and policies that were started in the 70s. In New York, we talk a lot about the Rockefeller drug laws, which were the first mandatory minimums where individuals were being sentenced to long terms in prison for possession of small amounts of illegal drugs. And that, in particular, judges had very little discretion in making those sentences because of these laws that demanded people serve these egregious sentences. And, this notion that we could, as in public policy, ensure public safety by taking a hard line on crime and a hard line on the drugs that were associated with crime, at the time seemed to be the right thing to do and what the public wanted. And there's lots of history that explains that. But here we are 30, 40 years later with the manifestations of these laws, and in some ways we've had to reform them or get rid of them entirely because of the damage that they have done and in many ways continue to do. Again, these were part of the just say no responses to drugs and the zero tolerance, the McGruff the crime dog, and just in general criminal justice approaches to individuals for nonviolent drug offenses. So preceding the crack epidemic were the laws that were developed to respond to the previous opioid epidemic. And so again, the recognition that mental illness and substance use disorder plays a large role in both the United States' role as one of the biggest countries to incarcerate, and that there's a lot that's happening. This generation recognizes that mass incarceration is the result of decisions made by generations before, but it is not an accident that the statistics, which many of you are probably very familiar with, that reflect how many women and men who are involved in the criminal justice system have also struggled with a mental health, a substance use disorder, in addition to poor health in general. and that we talk a lot about the racism that existed all along in the health field as creating a de facto health system to address substance use disorder and mental health issues, and then to consign black and brown people to that system. Women in particular have been hurt in the war on drugs for a variety of reasons, even though women generally make up a much smaller percentage of those who are incarcerated, and generally the default pronoun for folks who are incarcerated is male, but it has a unique impact on women in terms of women being more likely to be incarcerated for a drug offense, and that the disproportionate impact on women of color, despite the similar rates of using and selling drugs that's found among white women, and then also kind of the role of women in the drug schemes, if you will, is generally that of implicit or explicit bystander who is generally convicted being a part of an enterprise and not actually running the enterprise. But mostly the impact on women, removing them from communities where women's role as the glue to homes and community has been disrupted, and that impact we have seen in child welfare, in public benefits, in the education system, and the policies have essentially been very punitive and reactionary and hurt families much more than protect them. Media has done us no favors as well, and parenthetically, I know that you will be getting copies of the PowerPoint with the hyperlinks active in the PowerPoint, but this is just a very small thumbnail of some of the current discussion that's going on that very much harkens back to media coverage of black and brown people around drug use, around criminal justice, that seems to be emerging again as we deal with this current overdose epidemic. And whether it's the kind of sensationalistic articles like the recent one in the Washington Post, where black women's role is as enablers of black men who are using, or as never reflected in the articles that talk about the pursuit of treatment, the portrayal of white women and white families as being those who are victimized by the criminal justice or addiction or child welfare system in ways that are new to the general public. Media portrayals that are laced with hypocrisy. This link goes to articles about moms who say that smoking marijuana makes them better parents. And then, the denial of our mental health and emotional needs as this notion of strong black women taking charge and leading the way and being the moral compass of late denies us of our ability to be able to talk about these kind of struggles that are very real. Another one of my heroes, Dr. Mary Bassett, who was up until recently the commissioner for New York City Department of Health and Mental Hygiene, and that her primary agenda and kind of battle cry about health in communities was that it's impossible to ignore the impact that race has had in health, how health systems have been constructed, and how they have and continue to respond to our communities. And so I have a quote out of her famous New England Journal of Medicine article talking about Black Lives Matter in the context of our health. And that this is critical, that if we don't talk about it explicitly, then it perpetuates as we move forward. And that that's really the kind of time that we're in right now, where if we're not examining our past and past public policies meant to improve our health and social welfare, that we will perpetuate and create a bifurcated or dual systems that are segregated and that provide Black and brown communities with poorer health. One of the legacies of the harsh sentencing and the mass incarceration is that the impacts on our community are not just about the regular removal of men and women out of communities or in and out of communities, but that it takes also resources out of communities and embeds them or focuses them on the public safety side rather than the public health side. And so often in many communities where there is a major impact of incarceration or criminalizing behavior, there will be poor infrastructure in terms of public health or in terms of supporting schools or in support of safety net organizations. And so those features simply get transferred to the correctional health setting, and a cycle of in and out of communities back into the correctional health system, which does not enhance health, is what plagues many communities that are still struggling with the generational impacts of mass incarceration and harsh sentencing. And this has been very well chronicled. One of the especially compelling portrayals of this impact was from Columbia researchers Dr. Robert Fullilove and Peter Leone and Adora Adamora, who were trying to explain the impact of sexually transmitted infections in communities. And whereas the media or popular opinion would make presumptions about the kind of sexual behavior of individuals in these communities, this really is due to how incarceration and poor or negligent investment in community infrastructure creates sick communities that can't get well because of the imbalance that these kind of policies create. So in terms of simply the sheer number of women left in a community where many men have been removed creates networks that facilitate the transmission of sexually transmitted diseases, and it also impacts other chronic health conditions. So when we talk about racial inequities in health, we have to understand that much of how that has been developed has a lot to do with criminal justice policies, even though they're not seen as directly related. And then this then makes conversations about sexual behavior and race taboo, which therefore perpetuates the silence and lack of proactive response. So, the responses perpetuate the problem. And what we're seeing now is that we are demonizing and criminalizing some people, but sympathizing with others, that there's a kinder and gentler approach now to people with drug problems, whereas not even 20 years ago, people with drug problems had a choice of jail or enforced drug treatment. Now we're looking at drug courts that are focused on people who use opioids, and they're calling themselves opioid courts, and as if to respond to a single type of drug is the answer. And of course, implicit in making that distinction in opioids only is that the people who are perceived to be using opioids, or the innocent victims of the prescription painkiller epidemic, are in fact the worthwhile people, in fact the white people, and that others are, remnants of the crack epidemic, people who don't want to have treatment, don't want to have better lives or good health, and that is both explicitly and subtly reinforced by both policy responses to the overdose epidemic and media portrayal. And then the moral response in lieu of a clinical one, which really addresses how much discriminatory attitudes in healthcare continue to exist, whether it's the medical community assuming that black people with sickle cell are automatically also drug users, is part of the profiling that has happened and continues to happen in health that really puts our communities, and particularly women and families, at a serious disadvantage. Inadequate treatment systems that rely on approaches that are not evidence-based, or that the criminal justice system feels it can make informed health choices for individuals. And we're seeing this around the criminal justice system's response to medications to treat opioid addiction, which include methadone and Suboxone and Vivitrol. They're brand names, but that the notion of trading one drug for another, or that people will abuse, or the picture of people outside of a methadone clinic as reflective of who uses that medication, it's very much deeply ingrained in the public consciousness and even in the communities where these needs are being addressed. And so there's no gold standard, there's no consistency in the addiction treatment field, because there is a perception that addiction is still a quote-unquote behavioral issue that needs a corrective behavioral response versus as a health issue. And then we talk about the justice system being the de facto healthcare system for black and brown people, in particular for black and brown men. In many ways, the only health care that they get on a regular basis is due to their continued interaction with the criminal justice system. And then finally, we talk about harm reduction as a way to enable drug users and versus a compassionate response to keep people who are using drugs alive until or when they make a decision to enter treatment. And so the abstinence-based focus, whether it's urine tests or it's conditions for being able to get into inpatient treatment or get other kinds of health treatment, is very much rooted, again, in this notion of the behavior of an individual who uses drugs that needs to be corrected before they can be given the care that they deserve. All right, that's a repeat. We were having a technical glitch with the slides, so just bear with us as we get back. Okay, here we go. So it shouldn't be a surprise that the issues in trying to understand why people use drugs is now being very much an area of ripe for research, and that there is momentum to look at both preventative in terms of what are the factors that put young people in particular at risk for a lifetime of struggling with addiction issues, or that understand the and identify the symptoms that might reflect mental health issues. There's definitely an uptick in terms of the understanding and momentum for research around these issues. And again, this seems to coincide with the impact of the overdose epidemic among white people versus its impact on black and brown communities for the last 40 years. So notions of trauma-informed care, when we talk about the number of women involved in the criminal justice system, or even, just in terms of timely news, the Centoya's commutation, understanding that the trauma of her sexual assault as a child that ended up with her having a murder charge needed to be understood in a way that really acknowledges the multiple impacts of trauma and how that we have generally responded to it with poor or inadequate mental health resources or with the criminal justice system. We're acknowledging adverse childhood events and how they are subtle in their impacts that can then play out in not just a young person's life, but in their whole family interaction. And then this hierarchy of mental health care that sees addiction as a subcategory of symptoms rather than understanding that it can be an interplay with an existing mental health issues, that people can medicate with drugs undiagnosed or undertreated mental health issues, and understanding that we have developed whole systems responding to individual parts of people. So the same brain that's struggling with bipolar disorder can also be struggling with a cocaine addiction. And so to relegate treating the cocaine addiction to a whole different system then what is treating the bipolar disorder absolutely makes no sense. But again, that's part of the entrenchment of the stigma around addiction and around the systems or the perception of who struggles with addiction versus who struggles with mental health issues. Again, kind of thinking back to the impact, women are a smaller number in the criminal justice system, but the preponderance of mental health and addiction issues for women that are involved in the criminal justice system is totally disproportionate to their numbers. So you can see here 71% reporting exposure to domestic violence. The number of women using drugs prior to going to jail, the number of women expressing or showing or demonstrating mental health disorders while they're incarcerated, and the woeful lack of resources and responses and understanding in the criminal justice system to address these issues. So the services that women need on the outside are inadequate, and when they are unaddressed and end up as acute symptoms or acute actions that involve the criminal justice system, then this is compounded by even the trauma of being incarcerated. So we aren't breaking a cycle, we're perpetuating it, and this is something that is especially being demonstrated as we see more and more young women of color coming into contact with the criminal justice system. And again, understanding the intersections, we talk about intersectionality because we do, as women, coexist in exist in so many different planes, and as well as the public policy systems see us as distinct in each silo of care, which ends up being a great disservice to us. So looking at even the families that are impacted by incarceration, that leads to depression and anxiety and anger and stress, or understanding the overdose epidemic as a response to despair and struggle with education, struggle with opportunities for employment, struggling for stable housing. Again, understanding that we need to improve the system to treat the whole person, and that's especially true for women. We talk about, I often talk about, I'm the parent of two sons, and women generally will get addressed because of our reproductive health issues. But by the same token, men do not have a regular or counted upon way to interact with the health system. So the health system, both in terms of its racism and lack of knowledge about young men and men with emotional or mental health issues, has consigned a great number of them to the criminal justice system or to institutions, versus women, where we will at least have contact with the healthcare system through our reproductive capacity, but even then, the healthcare and social services systems like to look at us, black and brown women, as separate from the needs of our families and our children. So again, kind of the siloing is one of the ways that really does black women a disservice. And again, as the example, or as we are in this time of addressing the overdose epidemic, it becomes critical to talk about like core issues for women and a cultural competency in approaching the needs of Black women. And that is, we'll talk a little bit later about why we have to speak up through our electeds, as advocates, as people directly impacted, or these systems will not change. Apologies for the repeats. So this is identifying some of the barriers that keep people, but in particular for folks from communities of color, away from the healthcare system to address mental health and addiction issues. One is confidentiality, and that because of the stigma and because of the responses to health information being widely available, confidentiality is a critical element to protect in order for people to feel safe and come forward to access care. Legal Action Center works on a piece of federal legislation called 42 CFR Part 2, which was established in the 70s to protect the confidentiality of addiction-related health records, because so much of the addiction issues facing people were about interaction with illicit drugs. But if people felt that they were going to end up criminalized because they came forward for care, it defeated the whole purpose of trying to get people into care and into treatment and possibly on the road to recovery. And so we continue to need these protections of confidentiality even as we're in the day of electronic health record. And but do we actually know what is in our health profiles? And do we know who it's being shared with? And are we well informed with where our health information is going? And then who is making certain judgments about us based on our health information? Stigma, which I have recently been told, and it sounded very right to me, that whenever you hear the word stigma, think of it as oppression. That stigma really becomes this way to other people and to isolate people with issues that are perceived to be different from the general public. And so we have lived through the stigma of HIV and the stigma of mental health disorders and the stigma of addiction. And now, given where the opioid or the overdose epidemic is going, there is a great deal of effort to address the stigma that keeps people from coming forward, or that demonstrates that people are able to get well in addressing their addiction and mental health issues. This is one of the issues around methadone as a long-time medication in response to people with opioid use disorders. The people who are perceived to be outside of methadone programs and using other drugs, and the criminality that, the picture of the nodding individual who is using other drugs or abusing their methadone is popular but not accurate, and that the vast majority of people who are stabilized on methadone are tax-paying, family members, working every day, contributing members to society who, because of the stigma of addiction, will not come forward about their successes given the medications that they're taking to address their addiction. And so until we or that the fight never ends in trying to address stigma as a barrier to care, and also in changing hearts and minds. One area in particular that we at Legal Action Center have worked extensively on is insurance coverage for substance use disorders. And there have been a number of federal responses to this issue of insurance companies that have historically tried to pick and choose which health issues they are willing to cover and to what extent. Now, this has become an especially acute issue as we're dealing with this overdose epidemic and as people are understanding, especially on the commercial insurance side, that plans have created all kinds of hoops for individuals to jump through in order to get life-saving care. And the story of people getting denied coverage through the insurance companies and then dying of overdose is one that's very familiar in many of the communities that are struggling with the overdose epidemic. So in 2016, President Obama had signed as part of the Obamacare, the Mental Health and Parity and Addiction Equity Act, or the Parity Act, was embedded into Obamacare, into ACA, as a way to bring parity to insurance coverage of mental health and addiction issues that would be similar to how insurance covers general health issues, and to really start to get at that embedded discrimination in insurance coverage that treats issues of the brain, if you will, as different or less deserving of comprehensive coverage than is available or they're willing to apply for what we call medical surgical benefits. So I've, in terms of also individuals being unaware of their rights, under the Americans with Disability Act, there has been a number of individuals who've been either had their confidentiality violated or who have been forced off of their medications by the criminal justice system, by drug courts, or have been denied the ability to get the medications that they need. Many individuals think, who are struggling with addictions, think that this is okay to be denied care. And so there's a great deal of work that needs to be done to help individuals understand that they have rights that are covered and protected. And then finally, the funding, there have been a number of federal funding opportunities or funding initiatives to address the opioid epidemic, but again, the challenge of utilizing funds that are articulated as opioid only, but in fact need to address a wide range of issues that people face who are dealing with substance use disorders, that people use more than one kind of drug, whether illicit or legal, in terms of alcohol or in some states cannabis. So we talk about the CURE Act that was recently signed, H.R. 6, or CARE, a Comprehensive Addiction Recovery Act, and these are not only funding initiatives, but they're also legislation to change or address barriers to care for substance use disorders, which include having more healthcare providers able to prescribe medications, having more beds available for people to be able to get treatment on demand, building capacity, more capacity in communities where there is a shortage of services, substance use disorder or combined services treating both substance use, mental health, and physical health issues, encouraging community health care centers to develop competencies and provide broader array of services to address these issues. And again, each initiative speaks to challenges to getting care out to communities deeply impacted. One of the kind of tragic ironies is that there has been a significant shortage of addiction treatment services in communities that did not struggle 40 years ago with the burden of the impact of rampant drug addiction. And so the infrastructure to provide drug treatment and to provide care and to have practitioners who are knowledgeable about addiction care, we are doing a rapid ramp up to get that capacity available. One, because it has not been available in communities where maybe because of NIMBY issues, they did not want the methadone program in their community, but now are finding the need for it, and also encouraging practitioners, new nurses and new medical students to take on addiction care as a concentration or realm of study when, again, 20 years ago in medical schools, that was not at all featured as a priority area for study. So again, insurance coverage, the Affordable Care Act, the Mental Health Parity and Equity Act to address the role of payers and supporting addiction care and mental health, and the expansion of services to meet demand, addressing confidentiality, to encourage people to come forward and to really know that their rights and their confidentiality will be protected as they seek care. And then, again, kind of new initiatives to address the overdose epidemic that become opportunities to really expand systems and infrastructure that should have been in place in many of our communities in the first place. Under the current federal or current White House administration, there has been a number of efforts to address the overdose epidemic, but at the same time undermine some of the same systems that people need, such as implementing Medicaid work requirements or making SNAP, food stamp benefits conditional on these work requirements. So kind of giving with one hand and taking away with another. So again, this is just a kind of recap on what I was talking about earlier, and for those of us who are advocates who work at the local and state level, understanding that federal resources are new and available. Many have not even made their way to the states, but that to ensure that these resources get to the individuals that need them, there needs to be dedicated advocacy to ensure that the resources are going to the competent providers, are going to the communities with demonstrated needs, and are delivered with a competency that keeps people engaged. And so how we build that capacity on top of a healthcare system that has generally not been as responsive to the needs of Black and brown communities and to the needs of Black women is going to be a challenge, but this is the time to do it. This is the opportune time. Just so that people, for the advocates out there, Legal Action Center has developed profiles of healthcare information that become important to use with policymakers to make the case for the best uses of these of funding from these new initiatives. And for communities where the payer issues, the insurance coverage issues, and that includes Medicaid, are lacking, it's important to understand what the federal parity law in fact provides for and what advocates can work with their policymakers to ensure. I'm going to close with information about Legal Action Center. The best way to reach us is through info@legalactioncenter.org or subscribe to our updates and follow us on social media. In particular, if you're interested in our information on our No Health, No Justice campaign, simply put that in your request for more information in info@lac.org. And also these slides will be made available to you with active links so that you can use the resources that they connect to.
Oops.
Deborah, how are we doing with time?
We're there. So I want to say thank you again, Tracy. As always, this is an absolute phenomenal presentation. One of the questions we have is, do you have any data around trans women and trans men who may still be placed in women's facilities?
That's a very good question, and given the studies are scant, the research is scant, but there certainly is a disturbing prevalence of unaddressed substance use disorder and mental health issues for trans folks. So there are some national resources that talk about care that is sensitive to the needs of trans men and women, but I'm going to say that we at Legal Action Center don't have a lot of that information. We are working with organizations that serve the LGBT community who is involved in the criminal justice system and involved in the addiction system. But there is not a lot of information because not a lot of programs have that competency.
So, Tracy, we have time for one last question, and that is, I hear there have been some pressure placed on OASIS to address the issues of lack of safety space for drug treatment for trans women. Do you know anything about this?
I have heard that this has been an issue brought to OASIS and made a high priority. I know that one of the responses, in response, OASIS has developed a treatment bed finder that will allow for the sorting of information for programs that serve LGBT populations. So that is a recent development, and I'm certain that OASIS has other initiatives in place, including treatment initiatives at the LGBTQ center in the city, and also addressing these needs outside of New York City. So please keep an eye on OASIS on their website, which is undergoing a revamp, because those resources are going to be made available and prominent on the site.
Well, Tracy, I want to just say thank you again for an extremely informative presentation, and on behalf of the National Black Women's HIV/AIDS Network, please know that if you want to see any of the videos or presentations in this series, that all you have to do is share the link, register, and you'll be able to share these with your colleagues, your constituents, or show them in your communities. So on behalf of the network, we once again thank you, wishing everybody well and Happy New Year. And please look forward. We will be back in February with another one of our webinars leading up to the Synchronicity Conference in April in Washington, D.C. Thank you and have a great day.